So thank you very much for the invitation to speak. Just by way of context, I'm a neonatal clinician and I work in this beautiful city, which is Newcastle upon Tyne, which is in the north of England. And it's a big, busy and socially deprived setting where our breastfeeding rates are naturally low. So the audience will be familiar with this complex environment of the neonatal intensive care unit, but it's one where we're asked to make many practical decisions around feeding very early babies on a daily basis. So as well as that, I'm research active. I was one of the key members of the SIFT study that we'll discuss, but I also undertake mechanistic trials and I manage the Great North Neonatal Biobank. So what we're really talking about here is how we take a baby from a position where it's been intravenously fed in utero to hopefully a happy, healthy breastfeeding baby. And if you're a term baby, that journey is hopefully moderately straightforward and direct. But for our most tiny babies, that journey can be very complex. And it's complicated not just by the baby's physiology, but by the choices that we make every day around milk practices and feeding practices. And many of those practices are dominated by our desire to not ever have a baby develop this devastating condition of necrotizing enterocolitis. And whilst NEC is a very important outcome, it's not the only outcome that relates to how we introduce and continue to feed our very early babies. So I'm just going to spend a minute or two thinking about the outcomes that do matter and then what we should be aiming for as measures of success when we enterally feed. And as we do that, we need to remember that feeding babies is a complex intervention and that the relevant outcomes are multiple and potentially competing. We also need to remember that when we feed a preterm baby, we also feed bacteria. And there is this complex interaction between the bacteria that the baby is establishing in its gut and its health. So when the baby is allowed to host bacteria, those bacteria modulate the host response. And that modulated host response educates the immune system and in turn will alter the microbes the baby hosts. So this complex interlinked relationship exists and is influenced by our feeding practices. So I think the aims of early establishing feed are multiple. They involve minimizing threats to survival, and that's largely around reducing NEC and sepsis rates. They include optimizing growth, and we need to think about both the brain and the body growth. And ideally, they will optimize the microbiome and the metabolic functioning so that this preterm baby is optimally set up for a healthy later life. So when we think about when those outcomes are measurable, only some of them are measurable early. So threats to survival, NEC and sepsis and growth are, but the others are revealed only much later in the preterm baby's life course. So I think the outcomes that matter, and therefore what we should be aiming for, are no necrotizing enterocolitis, no late onset sepsis, and a healthy microbiomic and metabolic profile that lead to a healthy breastfed 1-year-old, and that should lead to healthy older age. And if we focus our efforts on breastfeeding, that we would also have positive societal impacts. So in an ideal world, we'd be able to optimize all of these outcomes, but it is likely that there will be some trade-off between optimal outcomes. So a summary key message slide, which is that the outcomes that relate to how we start and introduce enteral feeding are complex and potentially competing. Given the importance of this as a topic, you would imagine that neonatologists across the world would agree with how they do that, and therefore that time to full feeds would be pretty standardized. This study looks at that in 13 different NICUs on 5 different continents, with 5 of those in southern China. And what they actually demonstrated was a wide variation in time to establish full feeds at 120 mils per kilo, ranging from 8 days to 33 days. They also looked at those key outcome measures that we've just discussed and showed wide variation in mortality, change in Z-score from admission to discharge, and rates of NEC. But when they tried to link those outcomes to the time to establish full feeds, there was no clear relationship demonstrated between them. So the very beginning of our baby's journey is the introduction of enteral feed and the use of early colostrum. And for the most preterm, this is perhaps the most crucial window. So there is meta-analysis data of the use of buccal colostrum in preterm infants, looking at those key outcomes that we've discussed. And what that data show are that necrotizing enterocolitis rates, late onset sepsis rates, and mortality rates are not different in infants offered or not offered early buccal colostrum. But what early buccal colostrum does appear to do is improve immunological endpoints, and that's measurable in both urinary lactoferrin and urinary secretory IgA levels. And it's also been demonstrated that buccal colostrum leads to more maternal milk receipt over the preterm infant's early life course. So in the UK, the current British Association of Perinatal Medicine framework is that preterm infants should be expressing before 2 hours of age, and the baby should receive buccal colostrum within 6 hours. And that to achieve that, antenatal information should be provided where possible. And our own practice is to have colostrum kits everywhere and for everyone. And what this does is send an early message to mum that it's her milk that's important. And that early colostrum receipt also allows early bacterial seeding of the mother's bacteria with important impacts on baby's gut function. So that early first colostrum leads to more maternal milk receipt and will then lead to these additional benefits that we see early and later and very late in a preterm infant's life. So own mother's milk is the key to health, the food choice for all preterm infants. And we need to remember that maternal milk is much more than just the food constituents. It's a biologically active fluid, and it is the mechanism by which a conversation takes place between the mum and the baby. And that conversation is modulated through these products which are not present in formula feed and are often reduced in donor milk. So the next key message is that receipt of early buccal colostrum should be the aim for our preterm infants. The next question is whether we should aim to begin enterally feeding and increasing feeds early, or whether infants should deliberately spend a period simply receiving that buccal colostrum. And one of the key studies to help us in this is the ADEPT study, which enrolled infants with a gestation of less than 35 weeks and who were at the highest risk because of a combination of absent or reversed end diastolic flow and being born with a weight less than the 10th centile. So the interventions were to start to feed either on day 2 or day 6, and the outcome was the time taken to achieve full feeds defined as 150 mils per kilogram per day. And what you can see here are that those key clinical outcomes are not different in the two groups, but that the age at full feeds is different. So the infants who were fed early reached full feeds on day 18, as opposed to day 21 for the later fed infants. So there are 3 days less parenteral nutrition received by the early fed group. So that would suggest that the right thing to do is to offer to begin enteral feeding early. There is also meta-analysis data, which looks both at all infants and those specifically with absent or reversed end diastolic flow. And as you can see, there is no impact on neck rates by attempting to feed these babies earlier. So just some extra data to support the early use of maternal milk. So this is data from the Dutch group looking at the impact of how much of the baby's enteral feeding in the first 10 days of life was from maternal milk. And what you can see is that survival free of sepsis or neck is higher in infants who have the most maternal milk and lowest in infants who have none, with those receiving the intermediary with intermediate survival without neck and sepsis rates. So the next key message for us is that we should be aiming to start our feeds early. So our own starting approach is to view no baby as not being able to have buccal colostrum, that we wish to start sooner because that will lead to more maternal milk ever being received by the baby, but that in order to do that, we have to have mechanisms to have maternal milk available to us early in the neonate's life course. And our nursing standard is that our infants are fed unless they have specific instructions not to do so. We're also extremely careful not to waste those initial small volumes. So in the beginning, we give small boluses, we give it fresh, direct from the mother to the baby without freezing or refrigerating in between. We have strategies to try and improve our early maternal milk availability, which are around the unit culture and language, and everything that everyone thinks and says and does should encourage mums to be expressing their own breast milk. You need education and leadership to achieve this, and the assumption on the unit has to be that the tiniest preterm babies will receive their mother's own milk. And it is underpinned by this early receipt of colostrum. And some units actually go as far as prescribing mother's own milk for their preterm babies to demonstrate the importance of it. So the next key message is that we should be aiming to maximise maternal milk receipt early in the preterm infant. Our next challenge is to think about how quickly we should increase once that first milk has been introduced. So how fast or potentially how slow we should go. And you might imagine that these outcomes are competing. So neck might occur more commonly in a faster fed baby, and sepsis might occur more commonly in a slower fed baby. The key trial to help us understand this better is the SIFT trial, which is a very large trial of 2,804 infants, and importantly, all endpoints, so every case of neck and sepsis was reviewed by a blinded endpoint review committee. So the infants here are less than 32 weeks or less than 1,500 grams. The fast intervention arm were fed with an increasing rate at 30 mils a kilo a day, and the slower increasing rate was 18 mils per kilo per day. And the outcome was survival without moderate or severe impairment, alongside other clinical secondary outcomes, as we've discussed. So what you can see here is that neither the primary outcome nor the clinical secondary outcomes are different in the two groups, so that there is no significant difference there. But you can see that the infants who are fed faster achieve their full feed sooner, so on day 7 as opposed to day 10 for the slower fed infants. It's also important to recognise that infants were enrolled into this trial at a point when the physician was already ready to increase feeds, so not from birth, and the median age at which that happened was 4 days of age. One of the secondary outcomes was also motor impairment, and we did demonstrate a higher motor impairment rate in the infants who received faster feeding. We also undertook a health economic analysis alongside this and demonstrated that faster feeding was more expensive by £267 per baby. The meta-analysis data is shown here. It is dominated by the SIF data, but you can see that for mortality, neck, and sepsis, there is no difference in attempting to feed slowly or quickly. So the conclusions on increasing feeds are that the intention to feed faster achieves full feeds quicker, and therefore less PN is received, but this is only true once the clinician is happy to increase, and that in meta-analysis there is no difference in the key clinical outcomes. Therefore, that fast advancement may suit some babies, but the converse of that is that no harm has been shown by slower advancement either. So the key message here is that increasing in that range between 18 and 30 mils per kilo per day appears safe for the outcomes of neck and sepsis. So I want to think a little bit about milk tolerance. So if you have that set approach of early colostrum, early introduction of milk, and a moderate pace of progression, are there specific babies or specific symptoms where you should slow down? Or are there other things such as stool markers or urine markers or potentially breath markers, or even the development of a smart nappy that would tell us that this specific baby needs us to take a different approach? Well, when we think about all of those things and the possible things that would guide us, we need to recognise that many of those terms are very poorly defined. So distension, the colour of an aspirate, or the description of a baby as constipated is very subjective. And for most of these, there is either no or very low quality data. There is some data to guide us on the use of routine gastric aspirates. So 2 trials with a total of 141 infants. And what you can see here is that there is no difference in necrotizing enterocolitis rates, but that the time to regain birth weight was longer in infants where routine gastric aspirates was undertaken. So it's possible then that there is little benefit from this routine practice, but it's potentially very hard to stop when it's undertaken in most nurseries. And there is potentially a UK trial coming to try and guide us further. But the key message in relation to tolerance and using aspirates to measure this is that it's very subjective and possibly harmful. So the last thing we're going to think about now is how we monitor gut health. And given that the thing that we're trying to achieve is a happy, successfully breastfed infant, we could simply look at the proportion of our babies who end up in that position, or we could look at the converse and look at babies who experience adverse effects that are gut related. When we remember that the outcomes of interest are multiple, it helps us to think about how we might monitor our own success. So there are some endpoints that we would suggest are monitored locally by audit, so rates of neck, sepsis, mortality, 2-year neurodevelopmental outcomes and growth, although the definition of good growth is the subject of a whole separate talk. If units do this, they can then compare their own practice over time and with other units through things like the Vermont-Oxford network. But it's only really possible to do this for those early outcomes that we discussed earlier. We can then also potentially monitor the mechanisms by which gut health is mediated, but at present they're poorly understood. But it's possible that from the baby, we might develop and have soon available to us some bedside microbial or metabolic assays, either for stool or urine. And there are already laboratory assays that look at stool inflammation, which are potentially helpful. We need to also remember this key interaction with milk and the baby and the gut, And we should be looking at and recording our use of maternal milk and potentially thinking about the detail of that. So the HMO profile, the IgA profile, and the bacteria in the maternal milk, because those things are actually potentially modifiable in real time. And you'll hear more about those as the day's conversations go by. We then need to not forget the intermediates that tell us how we're doing with an individual baby. So the monitoring of routine biochemistry, micronutrients, glucose protein levels, and iron. And obviously growth is a key intermediate marker of gut health, but there are lots of issues around which standard of growth we should be aiming for. And likewise, microbiome monitoring and the use of pre and probiotics in your own unit and antibiotic use can all be monitored. So the last key message I have for you is that monitoring requires understanding of your own practice and outcomes and local audit. So a final word about parenteral nutrition. It's the unseen and largely non-discussed part of enteral trials when we discuss how we go about feeding our babies. There is data that suggests that acutely ill children may not benefit from early PN, but the nutrients deficits that a preterm baby experiences are already potentially large, even when we have early use of parenteral nutrition. And fluid management in our tiniest babies is extremely complex. It's also important to remember that preterm infants are not necessarily ill shortly after their birth when we're establishing enteral feeds. So to summarise, the key steps to take our baby from a 0 nil by mouth baby to a happy, successful breastfeeding baby are that the detail of our practice is what matters. Everything we do should be focused on babies receiving their mother's own milk as close to fresh as possible, including buccal colostrum before 6 hours of age, an early start to enteral feeding, with the progress driven by the baby and the knowledge that slower is not obviously harmful. We should take all steps to promote a healthy microbiome, including use of fresh maternal milk, thoughtful antibiotic use, and potentially the use of probiotics. And we should audit both our practice of these measures and the outcomes that we actually achieve. Gut health is unfortunately complex, hard to measure, and there is no single success measure and no single endpoint. It's important to measure locally your rates of survival, sepsis, NEC, and outcomes, but also to support trials that have these outcomes, whether they be pragmatic clinical trials or mechanistic trials. So I hope that that's been helpful. This is our research website where you can see more information. Thank you very much.